Welcome to This Week in Dermatology. This week we're covering 10 notable papers spanning the expanding reach of oral JK inhibitors into vitiligo and alopecia areata, safety and risk stratification at the intersection of skin disease and cancer, and evolving standards for how we define and deliver care in atopic dermatitis and scarring. Let's dive in. We start with the biggest story of the week, which is upadacitinib arriving in 2 diseases at once. In the Lancet, the Viti-Up program reported 2 replicate phase 3, double-blind placebo-controlled trials of once-daily oral upadacitinib 15 mg in adults and adolescents aged 12 and older with non-segmental vitiligo, enrolling just over 600 patients across 138 sites in 18 countries. At week 48, about 1 in 5 patients on active drug achieved at least a 50% reduction in total body vitiligo area, compared with roughly 6% on placebo, and around a quarter achieved at least 75% facial repigmentation versus 6 to 7% with placebo. Both co-primary endpoints were met in both studies. Put plainly, this is the first systemic therapy to show clinically meaningful whole-body repigmentation in a phase 3 setting, but the response rates are modest and slow. You are counseling patients toward a year of therapy for a 1 in 4 chance of substantial facial repigmentation. Reassuringly, over 48 weeks, there were no adjudicated major cardiovascular events, no venous thromboembolic events, no gastrointestinal perforations, no lymphoma, and no opportunistic infections other than herpes zoster. The same molecule looks considerably more potent in alopecia areata. JAMA Dermatology published the 2 UPAA replicate phase 3 trials, randomizing nearly 1,400 adults and adolescents with severe disease. Mean baseline SALT score of 84, so most of the scalp gone, to upadacitinib 15 mg, 30 mg or placebo. At week 24, roughly 45% of patients on the lower dose and about 55% on the higher dose reached a SALT score of 20 or less, meaning 80% or more scalp coverage against just 1 to 3% on placebo. Serious adverse events were uncommon, at under 2.5% on either dose, with acne, upper respiratory infection, nasopharyngitis, and raised creatine phosphokinase the usual suspects. That efficacy signal is far larger than in vitiligo. And it matters that adolescents were included, since ritlecitinib has been the only approved option in that age group. But before you assume JK inhibition is a durable fix, the Journal of the American Academy of Dermatology published a multi-center Italian real-world study showing that relapse of alopecia areata during ongoing JK inhibitor therapy is not uncommon, and that when it happens, it typically recurs in previously affected areas. Crucially, rescue outcomes were heterogeneous and could not be reliably predicted from baseline clinical features or from which rescue strategy was chosen. So the practical message is to warn patients at the outset that on-treatment relapse happens, to document the original pattern of loss, and to expect that salvage will be trial and error rather than protocolized. Also in the alopecia space, the journal Dermatology reported a global bidirectional cohort study using the TriNet-X network, propensity matching close to 70,000 adults with alopecia areata to controls, and screening more than 50 autoimmune conditions. Alopecia areata was associated with markedly elevated risk across endocrine, rheumatologic, gastrointestinal, and connective tissue disease. Cutaneous lupus risk was nearly 10-fold, systemic lupus nearly 6-fold, and vitiligo and Addison's disease each close to 4-fold. The relationship ran both ways. Patients with lichen planus, cutaneous lupus, or vitiligo had a several-fold increased risk of subsequently developing alopecia areata. Women with alopecia areata carried higher thyroid, rheumatologic, and cutaneous autoimmune risk, while men had higher vitiligo risk. This is retrospective claim-style data with all the usual surveillance bias caveats, but it supports treating alopecia areata as a visible sentinel of broader autoimmune susceptibility, with a low threshold for thyroid and connective tissue screening, particularly in female patients. The second theme is cancer risk, and here 3 papers converge from different directions. The Journal of the European Academy of Dermatology and Venereology published the SPIN-FRT consensus recommendations on biologic and oral targeted therapies for psoriasis and atopic dermatitis in patients with current malignancy, a history of malignancy, or elevated cancer risk, precisely the patients excluded from every registration trial. The expert panel concluded that overall malignancy risk with most of these agents appears low, though differences between drug classes may exist, and real-world data in patients with active or prior cancer remain thin. This is consensus rather than evidence, and the authors are explicit about that, but it gives you a defensible framework for the oncology co-management conversation rather than reflexive avoidance. On the surveillance side, JAMA Dermatology reported risk stratification models for skin cancer after blood or marrow transplant, built from nearly 3,500 survivors in the multi-institutional BMT survivor study. Using readily available variables age at transplant, sex, race and ethnicity, prior skin cancer, total body irradiation, chronic graft versus host disease, and post-transplant immunosuppression, the models achieved strong discrimination at 15 years, with area under the curve of 0.81 for basal cell carcinoma, 0.90 for squamous cell carcinoma, and 0.83 for melanoma. The separation is clinically actionable. 15-year cumulative squamous cell carcinoma incidence was about 3% in the low-risk group versus 14% in the high-risk group, and melanoma under 1% versus over 4%. Outcomes were largely self-reported with medical record validation where available, which is a limitation, but this is a practical way to decide who needs intensive dermatologic surveillance after transplant and who does not. Immunosuppression surfaces again in Acta Dermatovenerologica, in a retrospective single-center cohort of 400 patients with Merkel cell carcinoma. Among 241 patients with complete follow-up, a third of the cohort progressed, and of all the AEIOU diagnostic features, immunosuppression was the only one significantly associated with progression. The AEIOU heuristic remains useful for recognizing the lesion. It should not be repurposed as a prognostic tool. Finally, 3 papers on refining care standards. Acta Dermatovenerologica reported real-world lebrikizumab data from the Treat Germany registry, with 80 adults with moderate to severe atopic dermatitis followed to 6 months. Mean EASI fell from about 15 at baseline to 3 at 6 months. Peak pruritus scores dropped by roughly half, and dermatology life quality index scores fell from around 12 to 5. Importantly, patients switched directly from another advanced systemic therapy with no washout did just as well as those starting fresh. In the subgroup with baseline EASI of 16 or above, the trial-like patients, EASI 75 was 70%, and EASI 90 was 50% at 6 months, matching the phase 3 data. Adverse events occurred in about a quarter of patients, with conjunctivitis and other ocular complications the most common, reported in roughly 1 in 5. Alongside that, an International Society of Atopic Dermatitis position paper in the same journal argues that current treat-to-target thresholds capture severity but miss disease instability, comorbidity, family burden and treatment burden, and proposes a 4-domain framework covering disease activity, symptoms and function, global patient health, and longitudinal control. It is a conceptual roadmap, awaiting formal consensus and validation, not a guideline yet. And in JEADV, a Latin American Delphi study of 22 scar specialists reached consensus on 21 of 23 clinical scenarios for energy-based devices in keloids and hypertrophic scars, favoring vascular targeting devices and dressings for early inflammatory scars, intralesional steroid with 5-fluorouracil or bleomycin for actively growing lesions, fractional lasers only after flattening, and combination therapy over monotherapy throughout, with explicit safety caveats for higher skin phototypes. If you only have time for one paper this week, make it the Viti-Up trials in the Lancet. Vitiligo has had no approved systemic therapy at all, and this is the first phase 3 evidence that an oral agent can produce meaningful whole-body repigmentation in both adults and adolescents. That changes the counseling conversation immediately, even with modest response rates. Here are the key takeaways from this week in dermatology. Oral upadacitinib now has replicate phase 3 support in both non-segmental vitiligo and severe alopecia areata, with substantially higher response rates in alopecia. Counsel vitiligo patients that repigmentation is modest and takes a year. Expect on-treatment relapse in alopecia areata during JAK inhibitor therapy, usually in previously affected areas, and expect rescue to be individualized. Treat alopecia areata as a marker of broader autoimmune susceptibility and screen accordingly, especially thyroid and connective tissue disease in women. In transplant survivors and in Merkel cell carcinoma, immunosuppression is the dominant driver of cutaneous cancer risk and progression, and validated risk models can now direct surveillance intensity. And in atopic dermatitis, lebrikizumab performs in routine care much as it did in trials, including in direct switches without washout, while the field moves toward a broader, more patient-centered definition of disease control. That's your roundup for this week in dermatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.